Most people assume that if their blood tests come back normal, they are in the clear. That normal means healthy, that nothing serious is developing in the background. One of the most important things I have learned in medicine is that disease does not suddenly appear the moment a test finally crosses a diagnostic threshold. It develops slowly, quietly, often over a decade or more, while blood markers drift in the wrong direction but remain technically within range. The uncomfortable truth is that most of the blood tests we routinely rely on are designed to confirm disease once it is established, not to warn us when things are starting to go wrong. By the time a result is officially flagged as abnormal, the underlying biological process has often been deteriorating for years. Today, I am going to walk you through 5 blood markers that can predict serious disease long before any symptoms appear. These markers often change early. They are sometimes checked, but they are rarely interpreted properly in a preventative context. My name is Dr. Victor Hayes. I practice preventive medicine, and this is the kind of information I believe every adult over 40 should have. Let's begin. The first marker is high-sensitivity C-reactive protein, hsCRP. It measures something that sits at the center of almost every chronic disease, low-grade systemic inflammation. CRP is produced by your liver in response to inflammation anywhere in the body. The high-sensitivity version of this test can detect very small amounts, levels that would not indicate an acute infection or injury, but that reveal chronic, smoldering inflammation that has been quietly present for months or years. This matters because chronic inflammation is not something you feel. There is no pain, no fever, no obvious sign that something is wrong, yet it is actively contributing to the development of heart disease, stroke, type 2 diabetes, certain cancers, and dementia. It damages the inner lining of your blood vessels. It promotes plaque formation. It interferes with insulin signaling and accelerates cellular aging throughout the body. What makes this marker particularly valuable is that it often rises years, sometimes decades, before any disease is formally diagnosed. Here is the critical nuance. Many labs report normal as anything below 10 milligrams per liter, but optimal hsCRP is actually below 1. A result between 1 and 3 indicates moderate cardiovascular risk. Anything above 3 indicates high risk, even when cholesterol and blood pressure look completely fine. Research consistently shows that people with chronically elevated hsCRP at these seemingly modest levels have significantly higher rates of heart attacks and strokes over the following 10 to 20 years. The challenge is that CRP is often ordered but rarely properly contextualized. A single reading in isolation tells you relatively little because CRP can spike temporarily with a cold, an injury, or even intense exercise. What matters is the trend across multiple measurements over time. If your hsCRP consistently sits at 2, 3, or 4 across several tests months apart, that is chronic inflammation actively driving disease processes in the background, even if no individual reading alarmed your doctor. When you request blood tests, ask specifically for high-sensitivity CRP, not standard CRP, and ask to see the actual number, not just whether it was flagged as abnormal. The second marker takes us into metabolism, and it is one that almost nobody has checked despite being extraordinarily predictive. That marker is fasting insulin. When you eat, your blood sugar rises and your pancreas releases insulin to move glucose into your cells. In a healthy metabolic state, this happens efficiently with relatively modest insulin output. But when cells become resistant to insulin's signal, your pancreas must produce progressively more insulin to achieve the same blood sugar control. For years, sometimes decades, your pancreas can keep up with this compensation. Your blood sugar remains completely normal throughout. That is the critical point. Normal blood glucose does not mean healthy metabolism. Fasting insulin reveals how hard your pancreas is actually working behind the scenes. Someone might have a fasting glucose perfectly within the normal range, but need a fasting insulin of 15 to 20 microunits per milliliter to maintain it. Ideally, fasting insulin should be below 7. When it starts creeping into the teens or higher, that is a clear signal of insulin resistance. even while every standard diabetes screening test comes back reassuringly normal. Elevated fasting insulin predicts type 2 diabetes years before blood sugar rises. It predicts cardiovascular disease independently of cholesterol. Emerging evidence links it to Alzheimer's disease. Some researchers now describe Alzheimer's as a form of insulin resistance in the brain. The tragedy is that insulin resistance is highly reversible in its early stages through diet, exercise, and lifestyle change. But by the time someone is formally diagnosed with diabetes based on elevated glucose, significant damage has already accumulated. The pancreas is struggling. Reversal becomes considerably harder. Fasting insulin is not routinely checked in standard care because it is not part of diabetes diagnosis protocols. If you want to catch metabolic dysfunction early, ask for fasting insulin alongside your glucose and HbA1c. It will almost always provide information that those standard tests cannot. The third marker is apolipoprotein B, ApoB. This single measurement tells you more about your actual cardiovascular risk than LDL cholesterol ever could. ApoB is a protein that sits on the surface of every particle capable of causing atherosclerosis, the buildup of plaque in your arteries. Each of these particles carries exactly one ApoB molecule. Measuring ApoB directly counts how many atherogenic particles are circulating in your blood. This is fundamentally different from measuring LDL cholesterol, which tells you how much cholesterol is being carried, but not how many particles are carrying it. The distinction matters enormously. It is the particles themselves, not the cholesterol inside them, that penetrate artery walls and form plaques. You could have two people with identical LDL cholesterol levels, but one with many small dense particles and another with fewer larger ones. The person with more particles, higher ApoB, has significantly higher cardiovascular risk despite having the same LDL number. Studies consistently show that ApoB predicts heart attacks and strokes more accurately than LDL cholesterol alone, particularly in people with insulin resistance, where particle numbers and cholesterol content often diverge. Optimal ApoB is generally below 0.9 grams per liter. Anything above 1.2 indicates meaningful risk. Yet ApoB is rarely checked. Most standard lipid panels do not include it. Doctors make treatment decisions based on LDL alone, and regularly miss people with acceptable LDL but dangerously elevated ApoB. Conversely, some people are prescribed statins for moderately elevated LDL when the particle count is actually low and does not warrant treatment. For anyone with metabolic dysfunction, a family history of heart disease, or existing cardiovascular risk factors, requesting ApoB alongside standard lipids provides clarity that LDL simply cannot. The fourth marker bridges cardiovascular health and brain health, yet it is almost never included in routine blood panels. That marker is homocysteine. Homocysteine is an amino acid produced during protein metabolism. Under normal circumstances, it is rapidly converted into other useful compounds through a process called methylation, which requires B vitamins, specifically B12, B6, and folate. When these vitamins are deficient, or when methylation is impaired for genetic or lifestyle reasons, homocysteine accumulates in the blood. Elevated homocysteine is directly toxic to blood vessels. It damages the endothelium, promotes blood clot formation, and accelerates atherosclerosis. Higher levels are consistently associated with increased risk of heart attack, stroke, peripheral artery disease, and all-cause mortality. But beyond cardiovascular risk, homocysteine also appears to accelerate brain shrinkage and cognitive decline. Studies have shown that people with elevated homocysteine in midlife have significantly higher rates of dementia decades later. Brain imaging reveals faster atrophy in areas critical for memory. The mechanism involves both vascular damage reducing blood flow to the brain and direct toxic effects on brain cells themselves. What makes homocysteine particularly valuable as a marker is that it responds well to intervention. Optimal levels are generally below 10 to 12 micromoles per liter. If elevated, supplementing with B vitamins, Particularly methylated forms like methylfolate and methylcobalamin can reduce levels meaningfully within weeks. The intervention is nutritional, not pharmaceutical, which is precisely why it tends to be overlooked. The fifth marker is HbA1c, your 3-month average blood sugar. Most people know this as a diabetes diagnostic tool, but focusing only on diagnostic thresholds completely misses the point from a prevention perspective. What matters for long-term health is not just whether you are above or below the diagnostic cutoff, it is where your HbA1c sits within the normal range and how it is trending over time. Someone whose HbA1c consistently sits at 36 or 37 is in a very different metabolic state from someone whose HbA1c sits at 40 or 41, even though both are technically normal. That difference reflects chronic glucose exposure, which drives a process called glycation, the attachment of glucose molecules to proteins throughout your body. Glycation damages blood vessels, contributes to arterial stiffness, impairs kidney function, and accelerates aging at the cellular level. Higher HbA1c within the normal range predicts cardiovascular disease, chronic kidney disease, peripheral neuropathy, and cognitive decline, independently of whether someone ever develops diabetes. Beyond the absolute number, the trajectory matters enormously. If your HbA1c has been gradually rising over 5 or 10 years, even while every individual result was labeled as normal, that upward drift reflects worsening insulin resistance, declining pancreatic function, and accumulating glycation damage throughout the body. Catching this early, when HbA1c is still in the mid-30s but trending upward, gives you years to intervene before irreversible damage accumulates. HbA1c is used as a binary diagnostic tool. You either have diabetes or you don't. The nuance of optimal versus acceptable versus concerning but still normal is lost. Track your own results over time. A gradually rising HbA1c is information that a single normal reading cannot provide. Finally, I want to mention one additional marker that almost no one has heard of, including most physicians. That marker is GlycA. GlycA is a composite biomarker that measures the glycosylation state of acute phase proteins involved in inflammation. What it captures is your body's long-term inflammatory burden. Unlike hs-CRP, which can spike and fall rapidly in response to acute illness or stress, GlycA reflects chronic, sustained inflammation. It is more stable, less volatile, and potentially more predictive of long-term disease risk. The research on GlycA is relatively recent, but the findings are striking. Elevated GlycA predicts cardiovascular disease, type 2 diabetes, and all-cause mortality more strongly than many traditional markers. It integrates information about inflammation, metabolic dysfunction, and protein glycation into a single measurement. If hs-CRP is a snapshot of inflammation at one moment in time, GlycA is the long exposure photograph capturing what has been happening across months and years. GlycA is not included in any standard blood panel. It requires specialist testing through advanced metabolic profiling. But for those of you serious about understanding your long-term trajectory, particularly with a family history of cardiovascular disease, dementia, or diabetes, it offers a level of insight that traditional markers cannot match. Let me close with the practical takeaway. If you are over 40, if you have a family history of heart disease, diabetes, or dementia, or if you are experiencing unexplained fatigue, brain fog, difficulty losing weight, or poor recovery from exercise, these are the markers worth tracking. Ask specifically for high-sensitivity CRP. Ask for fasting insulin alongside fasting glucose. Ask about ApoB when you get your cholesterol checked. Request homocysteine if cognitive health is a concern. And look at the trend in your HbA1c over time, not just whether it crossed a threshold. The goal is not to collect numbers obsessively. The goal is to identify problems early when they are still highly reversible, and to confirm that the dietary, exercise, sleep, and stress changes you are making are actually producing the biological results you intend. Prevention requires anticipation. Health is not a switch that flips from fine to diseased. It is a gradual drift in one direction or another. These markers show you which direction you are heading years before you arrive at the destination. That information is everything, because it gives you time to change course. If this was useful, please subscribe to this channel and leave a comment below telling me which of these markers you are going to ask about at your next appointment. I read everyone. I will see you in the next video.